Um, okay, everybody. Hi there. Good to be back. Really sorry about that first interruption. So what I'm going to be doing is talking to you about MDMA and how that can be useful in the treatment of trauma-based disorders, and particularly those that are due to trauma in childhood. I started with just a little bit about how poor modern psychiatry is at managing trauma-based disorders, and we'll hear a little bit more about the prevalence of particularly addictions and trauma-based disorders and how hard they are to treat. And I was just talking about different forms of physical, sexual, emotional abuse and neglect in childhood, and how these have such an impact on the development of a person's personality. Of course, it's not just, there's many factors that come together for the development of a mental illness. All mental health problems are what we call multifactorial. So it's not only that you have, unfortunately, the genes that code for depression, anxiety, personality disorders, eating disorders, psychosis, addictions, but also those of us working in mental health know that we work with people on the bottom rung of the ladder in terms of multiple psychological and social risk factors as well. So all of these things: unemployment, poor housing, poor education, parental criminality and mental illness, domestic violence, racism, exclusion, these are all big factors that impact upon one another. So to develop a full-blown mental disorder or illness, you usually have multiple risk factors, and any kind of positives or strengths in any of these areas can protect you against actually developing the disorder. So it really is a very unfortunate position for most of our patients. Now, here's a brief physiology lesson for you. There's a picture of the brain there. We can roughly split the brain up into three different areas. The lower part there, the brain stem, this is a very basic bit of neurophysiological functioning. This is the part of the brain that measures and manages your heart rate and your breathing and your blood temperature and your blood pressure and your blood chemistry. And it's really basic. Cockroaches have that. It's nothing particularly sophisticated. If we move up a little bit further from an evolutionary point of view and upwards towards where that red dot is, we often call that the midbrain area or the mammalian brain. And that red area there is the amygdala. Now, all mammals have an amygdala. It's a much more sophisticated part of the brain. It's where we have emotions. So cats, dogs, shrews, giraffes, elephants, they all have emotions to some extent. They respond to fear. And when exposed to a fearful stimulus, it triggers a hormonal response called fight, flight, freeze. Now, no thought is required for this. It's what we call a bottom-up process. So, you know, if I'm sitting here now and someone comes into the room with a knife running towards me, my amygdala will be triggered. And there's no thought required. It's very much an instinctive knee-jerk reaction. And the amygdala then triggers this hormonal reaction, which prepares you to deal with the situation. Now, if we go further up the evolutionary scale, that green area there, that's the prefrontal cortex. Now, the prefrontal cortex is really a uniquely human part of the brain. It's where we have much more sophisticated aspects like planning, rationality, logic, reasoning, and and this green area, the prefrontal cortex, is in constant communication with the amygdala. So and it can overcome this instinctive amygdala response. So if you imagine the person comes into the room with the knife, the amygdala fires, says, I'm in danger, I've got to get out. Fraction of a second later, prefrontal cortex kicks in and says, actually, I reckon I can reason with this person. It's not that bad. Now, if you've had a lovely, nice upbringing with love and care and nurturance from your primary caregiver, then you're very good at overcoming this fear response. But if you've grown up in an experience of childhood trauma, where you never know when your caregiver is are they going to give you a kiss and a cuddle and play with you and be a kind parent, or are they going to kick or punch you or rape you? What happens is you actually grow up with physical brain changes. You have an increased network and connectivity in the amygdala. So in other words, you become almost permanently highly tuned to fear, and you find things fearful and painful for the rest of your life. And also that green area, the prefrontal cortex, is attenuated. You don't get such good growth of that part of the brain, so you're not so good at talking yourself down off fear. So this is one of the sort of physical brain changes that happens as a result of childhood trauma. Now, when going back to attachment again, If you're lucky enough, which most people are, to have had a secure attachment from your caregiver as a child, then you build up these narratives of the self. I'm a good person, I'm achievable, I'm lovable, and also the world. People are good, the world is to be trusted, people will help me. And that's how we see the world. Now, if you've had an insecure attachment, if you've been exposed to fear and trauma through all your early years, then you have these very negative narratives that arise. I'm useless, I'm terrible, I'm unlovable, it's my fault, I deserve to be exploited. And also these narratives of the world. Everyone is dangerous, people are out to get me, trust no one. And this is a very, very overwhelmingly awful position to be in. And that's why so many people in that situation find that the best option for them is to numb themselves, block out the world with sedating substances. So they may choose dangerous substances such as heroin, or much, much more dangerous substances such as alcohol, in which to sedate their brain. Now, it's very difficult to treat childhood trauma, post-traumatic stress disorder, complex PTSD, addictions, all of which are trauma-based disorders. It's difficult to treat them because we're not treating the root cause. What we're doing is we're papering over the cracks with symptomatic relief. So what we have then is polypharmacy. This is being on multiple medications because we treat the symptoms. So if the patient can't sleep, give them a hypnotic. If their mood is unstable and goes up and down, give them a mood stabilizer. If they're depressed, give them an antidepressant. If they're hypervigilance, this sense of edginess that goes with PTSD becomes excessive, give them an antipsychotic. And so they're on all these drugs, all of which just treat the symptoms, but not the underlying cause, the trauma. Now, a good example, good analogy here is if you have a infection, which is due to a bug, a microorganism growing in you or on you, one of the symptoms of an infection is a fever, a high temperature. Now, you can take a drug like paracetamol or ibuprofen to bring down that temperature, and that makes you feel better. Sure, good idea. Why not do that? But you'll feel a bit better, but you're not going to kill the bug. Paracetamol, ibuprofen, they're not antibiotics. They're not going to kill the cause of that infection. They're just going to treat the symptom, the fever. And that's what we do when we give our patients long-term antidepressants, sleeping tablets, etc. We're just treating the overlying infection. And it's a bit like, I don't know, breaking your leg. And instead of getting the bone set by a surgeon, you just keep taking painkillers for the rest of your life and you walk around on a wobbly bone. That's kind of what we're doing when we give these long-term maintenance psychiatric drugs. So it's very difficult to treat, and we have polypharmacy. We also have polypsychotherapies, multiple different forms of psychotherapy that people use to try and address the trauma. And it's difficult because this is effective in some people, but a significant number of people just do not want to go there. By the time they're in their 20s or 30s or 40s, and they've got a severe anxiety-based disorder such as PTSD or any addictions that are due to childhood trauma, they've become an absolute expert at ever talking about their difficulties. They've become super efficient at avoiding those painful childhood memories. And the result is we have these high rates of treatment resistance. 50% of people with these trauma-based disorders have a chronic form of the disease, which they just cannot use. The current medications and psychotherapies are ineffective. And of course, they have high rates of suicide and self-harm as well. Now, going back to psychedelics, psychedelics have a very rich history in the treatment of addictions. Indeed, most of the work of the 50s and 60s was with LSD psychotherapy for treating alcoholism. And the rationale behind this is that if you induce an intense organic psychosis, this kind of has a natural sobriety that goes on. Now, you can define a psychedelic experience as an organic psychosis of some kind, very safe one in terms of physiologically, but it does seem to have this bizarre effect of once you've glimpsed those psychospiritual mystical realms with a high dose psychedelic, you lose interest in the addictive compound like alcohol. So a lot of work was done in the 50s and 60s. This is Humphrey Osmond and Abram Hoffer, their team in Canada. Their research was recently revisited, a meta-analysis of the work done from the 50s and 60s, and the results were very strong in terms of favouring LSD as a treatment for alcoholism. Here's a strange fact a lot of people don't know. Alcoholics Anonymous, which is universally known as this very drug-free approach. Well, Bill Wilson, the chap who invented or came up with AA, was actually had some important high-dose LSD experiences in the 50s. And when he talks about the higher power and the idea of communing with a mystical experience to treat alcoholism, he's actually referring to LSD. And it's interesting how AA have kind of eradicated this history from their own history, that LSD played a big part in the development of their service. Psilocybin, which is the active component in magic mushrooms, this has been revisited to treat alcoholism in recent years. This is Michael Bogenschutz in New Mexico who did a study, and he found, similarly to the Osmond group in Canada, that the greater the psychospiritual effects of the psilocybin experience, the greater the mystical effects, the greater the level of abstinence they found in treating patients with alcoholism. So that was an interesting finding. Now, I want to just quickly turn to 3,4-methylenedioxymethamphetamine, MDMA, a really remarkable molecule. Now, when we started looking into whether we could use this to treat addictions, we sort of hit a bit of a brick wall. We knew that it works really well with trauma and empathy because there'd been all the PTSD studies. But what MDMA doesn't tend to do very often is induce a mystical or spiritual experience. I'd say about 5 to 10% of people on first-time threshold dose MDMA or ecstasy will describe a mystical experience, this communing with God, but which is not very high, and certainly not as high as the sort of 80 to 90% that people who take high-dose psychedelics like LSD or psilocybin report. So we did wonder whether it would work. Now, it worked very well indeed. So in terms of MDMA, I've often described it as the perfect tool for trauma-focused psychotherapy. Short acting is about sort of 2 to 6 hours. It's mildly perceptually disturbing, but it's not ego dissolving like classic psychedelics. It's almost always pleasurable. That's a very important feature in a drug. There are a few drugs that are almost always pleasurable. I suppose the opiates are another one. I've given diamorphine or heroin to many people over the years as a doctor, and they all love it. Similarly with MDMA, it either works or it doesn't, but you don't really get a bad trip like you do with the classic psychedelics on some occasions. So that's important because it means it's clinically deliverable and tolerated. It's also very, very safe. I used to talk a lot more about trying to justify the safety of MDMA. I've been doing these talks for 15 years. I don't do that anymore. There's just so much data about the safety of MDMA, and I'm happy to talk more about that if there's some more questions. But it's really this access to the painful traumatic memories and its ability to enhance empathy that makes it so important. If we look at how it works in the brain, a lot of people think, oh, MDMA raises serotonin. It's a bit more sophisticated than that. There are many different subtypes of serotonin. Serotonin is also called 5-hydroxytryptamine, 5-HT. Now, at the 5-HT1A and 1B receptors, this is where you get the classic euphoria or ecstasy, if you like, reduction in depression and anxiety, and also this reduction in fear and increase in self-confidence. It also has a mild effect at the 2A receptors. The 5-HT2A receptors are where the classic psychedelics, LSD and psilocybin work. And there is some effect there with MDMA, but a lot less than with the classic psychedelics. So as I said, we don't get the ego dissolution. You don't get the sort of melting faces and dripping walls and those kinds of perceptual distortions you get with classic psychedelics. But you do get enough of a sort of original thinking, alterations in meaning, which is very powerful as a psychotherapeutic tool. Next there, we've got this very weird paradoxical situation whereby the amphetamine part of the molecule via dopamine and noradrenaline has a stimulatory effect. And this is a bit like amphetamine or cocaine in some ways in that it speeds you up. And this is good because this increases your arousal and motivation to take part in therapy. But what you've got happening paradoxically at the same time is a relaxation effect via the alpha activity receptors. And anybody who's taken ecstasy would be familiar with this peculiar sensation of being both speeded up and slowed down at the same time. So it's like, you know, taking ecstasy, you're not on the dance floor, you're speeded up and you're stimulated, but you're also much more chilled than if you'd just taken cocaine or amphetamine, which are just much more purely stimulants. So it's a strange situation there. And then we've got a hormonal effect, which is the release of oxytocin. And as you know, oxytocin is the hormone released from the brains of breastfeeding mothers. It's a hormone that engenders a sense of empathy and bonding. And attachment. Now, when you add up all these things together, what you have is this positive mood and creative thinking, this paradoxical stimulation and relaxation at the same time, and this massive capacity for empathy and bonding. What this does is, and this is a very neat phrase, it selectively inhibits the fear response whilst leaving the other faculties intact. Very important statement, that. Now, many drugs inhibit fear response. A bottle of vodka will inhibit your fear response. A bag of heroin will very effectively inhibit your fear response. But heroin, opiates, alcohol, these are very messy drugs. On those drugs, you can't really do any psychotherapeutic work. You can't debate and remember and reflect on past memories, and you certainly won't remember it the next day. So MDMA has this very unique ability to just take out the fear, but leave all those faculties intact. And here is our traumatized brain that I talked about earlier. This is the child who is now an adult and has this hyper excessive amygdala response due to this exposure to frightening experiences as a child. And they have that shrunken prefrontal response, this inability to see the good in themselves or others. On MDMA, you have the exact opposite. And this was a study done at Imperial a few years ago. You shrink the amygdala response. You turn off the amygdala. The fear center is turned off. And the prefrontal cortex, the part of the brain where we use logic and reasoning, is boosted. So you're in this very strong capacity from a psychotherapeutic response to really tackle difficult to access, painful, traumatic memories when you have the MDMA on board. So there's a picture of our study team. What we decided to do then was do an open label safety and tolerability study. Now you may say that doesn't sound very methodologically sound, no control group, no placebo, but when you do a new drug in a new condition, as we were doing for the first time, you have to use an open label study. And what we have is a 8-week course of psychotherapy. Now, all the patients came in as daily heavy drinkers, drinking between 50 and 300 units of alcohol a week. That's a large amount of alcohol. They all then underwent a detox in which they take a medical drug called chlordiazepoxide or Librium, which brings the alcohol down to 0. And then at the end of the detox, they went into the 8-week therapy course. This was 10 sessions of psychotherapy, on 2 of which they take MDMA. So a very typical protocol for a psychedelic psychedelic course. It's not just taking the drug. You always take the drug sandwiched between non-drug sessions. And it's the non-drug sessions that are so important in terms of preparation and then integration of the experience. The drug sessions themselves were all day long. They stayed all day. They spent overnight in the research center, and then they had a session the next day. Now, during the drug sessions, they're very non-led by the clinician. The client leads the sessions. A lot of time is done what we call inside. So the patient is just lying there on the bed with eye shades on and headphones in darkness, listening to music with the drug experience. There's some degree of talking or psychotherapy that goes on during the MDMA experience, but most of that work goes on outside of the drug session. During the drug session days, it's very much about being with the experience and seeing where that takes you. And then, of course, we followed them up at 3, 6, and 9 months to collect outcome data. Now, I love this table. This is a spectacularly boring table that says absolutely nothing whatsoever, which is fab, which is exactly what we wanted with a safety and tolerability study. In other words, we had no abnormal changes in terms of physiology, we had no adverse events, and we had no deaths. Everybody tolerated the program very well. There were no suicides or self-harm or risks. There were no abnormal blood changes, no abnormal ECGs. So in other words, spectacularly boring, but excellent results. Everyone tolerated the treatment. And as I said here, MDMA is a remarkably safe compound, very low rates of morbidity or mortality. And where there are difficulties with, say, physiological changes, these are all very easily controlled in a clinical setting. And the take-home message here is that clinical MDMA is not recreational ecstasy. It's a very different drug. It's pure MDMA, 99.98% pure we used. And these are screened patients, very heavily monitored. So you really can reduce the risk right down to close to zero in terms of the MDMA causing any harm. Now, even if we do look at ecstasy, let's look at ecstasy. 750,000 doses of ecstasy are taken every weekend in the UK. 750,000 doses of ecstasy every weekend have for the last 30 years. That's how heavy ecstasy use is. Yet the rates of morbidity or mortality are staggeringly low. It really is not a drug that's on the radar as a public health concern, despite it being very heavily used. So it's a very safe drug. And you may consider that controversial. And of course, there are some tragic high-profile deaths of young people who take MDMA or what they thought was MDMA. And there's only a few a year, a handful a year. But you can bet your life that they all get on the front page of the Sun, leaving this perception that ecstasy is a dangerous drug. It simply is not. If it was a particularly dangerous drug, we'd know about it by now, given the massive epidemiology of its use. Nevertheless, in its wisdom, the ethics committee asked us to carry out all sorts of physiological testing. These are the pooled results of 26 MDMA sessions. The lines at the bottom there are blood pressure, heart rate, and temperature, all of which go up slightly and then plateau and then come down by the end of the session. The green line is the drug effects, which obviously go up and then come down by the end of the session. And the brown line there is anxiety, which starts slightly high because patients were a little bit anxious as they came into the session, but always comes right the way down to zero as the MDMA takes effect. So again, a spectacularly boring graph there because it just shows that everything stayed normal. People often ask this, what about comedowns? What about Blue Monday, Black Tuesday, Suicide Wednesday, whatever ravers call it these days? We didn't see that. We measured that very carefully. Nobody got any comedowns. Everyone tolerated the drug well. They felt great at the end of the day. They ate, they slept well. And indeed, we measured their mood state for the 7 days after each MDMA session. And not only was the mood not depressed, so on this scale, any positive numbers are depression. 0 would be what we call euthymia or normal mood. Negative numbers on this POMS scale, the profile of mood states, mean a positive mood. So as you can see from those results there, across the sessions, all the patients actually felt great. They had a positive afterglow effect that lasted for a week. So this whole concept of this Blue Monday, Black Tuesday, we just didn't see it when MDMA was delivered in a clinical setting. Now, looking at the drinking behavior, what we did before the MDMA study, we decided to look at how people were doing in Bristol without MDMA. So this line here, we did an observational study. So these are patients that were coming into Bristol for detox. They all come in with high levels of drinking each week, so 159 units a week there at the beginning before screening. They all undergo their medical detox and drop down to 0. Then without any intervention from our MDMA team, but just whatever the gold standard is for treating people with alcoholism these days, we then measured them up for 9 months, follow them up for 9 months to see how their drinking changed. Now, they got all sorts of interventions in this study. This was not MDMA. What they got was MAP groups, AA, rehab groups, anti-craving drugs, group psychotherapy, one-to-one psychotherapy, basically the very best gold standard treatments that modern medicine can throw at the alcoholic post-detox. And sadly, and not unexpectedly, look what the outcomes were. By 9 months, most people were back to drinking the high levels of alcohol that they'd gone in for. So in other words, a spectacular fail in terms of current best treatments for alcoholism. Now, if we compare that with the MDMA group, here they are coming in with a high level of weekly drinking, dropped down to 0 during the detox. And then we followed them up. Then they got the MDMA group after the MDMA treatment after the detox, followed them up for 9 months, and very much lower rates of drinking. Now, if we superimpose those two graphs, I've changed the scale slightly there to include the definition in a percentage of those people drinking over 14 units a week, which is one of the criteria for alcohol use disorder, over 14 units a week. 100% of people in both groups drinking over that before they came in. They all go down to 0. And then the red line there is the observational study, the outcome study. And the black line is the MDMA study. And you can see the 8-week course of MDMA therapy that went on. Now, those are staggering results, however you want to look at it. Now, this was a non-randomized study. These are not two different groups in the same study. The red line is the treatment as usual group. The black line is the open label MDMA group. So in that respect, we can't statistically compare these groups, but that is a staggering result, however you look at it. You don't see graphs like that in human psychopharmacology studies. It's a fantastic result, and we're very proud of that. Some qualitative statements here, demonstrating some of the positive things that our patients said. They tolerated it very well. They found it to be much better than previous treatments they've had for alcoholism. And remember, a lot of these people had like 10 detoxes in the past. So it was really gratifying to see the good results there. And I guess the next step, what do we do? Well, we need to do a randomized control study to test the efficacy of MDMA. So that was an open label safety and tolerability study. The next thing to do is to test MDMA assisted psychotherapy against placebo assisted MDMA psychotherapy to see if we can demonstrate it's the MDMA and not the psychotherapy. Just run through a few interesting questions here. These are some of the theoretical objections and challenges to why psychedelics are difficult to use clinically. People say, oh, well, you're just swapping one dangerous drug for another. Or they may say there's a risk of addiction to psychedelics. Or they may say there's a lack of proven research efficacy in psychedelics. Some people would say studying psychedelics sends the wrong message about drug policy or encouraging people to take drugs. Certainly, some people would say this is very costly and difficult to do. And also, there's no doubt that there's this stigmatizing public belief about psychedelics, which are all challenges. But just to run through these. So swapping one dangerous drug for another. Well, that's absurd. There are very few things you can do to yourself in life that are worse than drinking a bottle of vodka a day, or a bottle of wine a day for that matter. Or smoking cigarettes for that matter, or any of the other dangerous activities in addictions that we target. So the idea of using MDMA 1 or 2 or 3 times in a controlled clinical setting, if that can get you off the vodka, then that's an extremely positive and safe thing to do. So that first objection is rubbish. The next objection, risk of addiction to psychedelics. Psychedelics have a very low addictive potential. We just don't see that. We don't see it in animal studies. Animals don't self-dose with psychedelics like they do with alcohol, cocaine, amphetamine, nicotine, etc. Very low risk in animal studies. And epidemiologically, you don't get drug-seeking behavior for psychedelics. No one's going in and breaking into your car to nick your stereo in order to get their next magic mushroom fix or their next ecstasy fix. It's just not on the radar for drug services. So that's not true at all. Lack of research of proven efficacy. That's just not true. Our study, every single psychedelic study of the last 15 years, not only have the results been good, they've been amazingly good. For every single condition that's been looked at with psychedelics, the results have been superb. So the research efficacy is actually very strong indeed. Sends the wrong message, read drug policy. Now, don't even get me started in talking about drug policy, because I'll be here all night. The correct message for drug policy should be the truth, as David Nutt said, about the real risks and dangers and benefits of psychedelic drugs. It shouldn't be some predetermined government idea based on God knows what, history and racism from what I can see. So the correct message should be the safety and efficacy of these drugs because it's well established. Costly and difficult, yes, very costly and difficult. And this stigmatizing public perception about psychedelics is absolutely true. So these are some of the challenges we're up against. There's a picture of me DJing in the 90s when I first became exposed and understood about MDMA as a potential beneficial clinical tool. I still DJ today. I'd encourage people to get involved in both DJing and psychedelic research. This is a bit of a shameless plug for my book, The Psychedelic Renaissance. It's really interesting, actually. Last few years, we're hearing this word psychedelic renaissance all over the place. Everyone's calling their conferences psychedelic renaissance, blah, blah, blah. I wrote this book over 10 years ago. I didn't coin the phrase. I just heard it somewhere at the time, but it's amazing how popular this is now. So I do urge you all to remember there is a book named after this. Also, the other thing about the concept of this modern psychedelic renaissance, we are now in psychedelic research, we far eclipsed the 60s. People talk about the psychedelic 60s. There is far more going on today around psychedelics than there was back then, both in terms of psychedelic research and medicine, clinical programs, but also culturally. There's way more people taking psychedelics recreationally now than there ever was in the 60s. There's all these psychedelic societies, there's this wonderful networking and cohesion. So this really is the psychedelic era, not the 1960s. And it's been a great pleasure for me to take part in all of these different researches of the last 15 years. I've been a research test subject. I've administered LSD, psilocybin, ketamine, DMT, and MDMA. And I've also received all of those drugs, most of them intravenously, as a research subject in all these different studies, most of which have come out of Imperial College London. So great pleasure to be involved, and I urge you to get involved. Finally, a couple of slides about the Awaken Psychedelic Clinic. This is the UK's first clinic offering psychedelic assisted psychotherapy. We are opening in the next few weeks, and we're in Bristol. We have a superb scientific advisory team with Matt Johnson, Mitt Hoffers, and Celia Morgan, chaired by myself and David Nutt. And at Awaken, we've got these three main revenues that we're doing. One is offering psychedelic clinics, initially with ketamine assisted psychotherapy. We will also be providing training for people wishing to become psychedelic therapists, and we will be carrying out research initially with MDMA. So lots of interesting stuff going on in Bristol. There's some great old pictures of the clinic. It's now looking a lot more beautiful than that. We're opening in a few weeks. I do urge anyone Bristol way to drop in and say hi. Picture of Sigmund Freud. And I think I will make that my final slide. This was a placard of the recent street protests by, I think, the Occupy movement. What do we want? Evidence-based change. When do we want it? After peer review. And I think this really emphasizes the importance of, this is not some crazy fringe subject. This is not just some maverick idea. This is cutting edge neuropsychiatry. This is where modern brain science is now. It's not just some fringe thing. It's happening all over the world in major reputable scientific institutions. Psychedelics is where it's at. I urge you as young people to get involved. It's still in the only earliest days of its development, and there's plenty of room in this space for everyone. So do get involved. And thank you very much.
Brilliant. Thank you, Dr. Sessa. That was absolutely fantastic talk. I have seen you talk before on the same topic, and it's amazing to be able to hear it again. Really interesting talk. So,
thank you very much. So have I stopped sharing? Yeah.
Sorry, go on, what was that?
I've stopped sharing my screen.
You have, yeah. Okay, so first of all, I just want to say a massive thank you to everyone for being so patient. It's amazing still to see almost all the participants back. Unfortunately, we haven't had any more interruptions. So there have been a few questions that have come through for you. So I'm going to read them out for you, if that's okay.
Yep.
So first one I've got here is from Hannah. MDMA is sometimes referred to as a psychedelic, but sometimes not. Do you have a precise definition of a psychedelic?
Sorry, I talked over you there. Did you say MDMA?
Yes.
So MDMA, is it a psychedelic? Good question. Thank you, Hannah. Well, I mean, we often talk about, in terms of defining psychedelics, there's so many different ways to define them. You can define them by structure, you can define them by the mode of action in terms of the receptors where they work. And we often talk about what we call classic psychedelics. And this would be those that are 5-HT2A partial agonists. So LSD, psilocybin, DMT, and mescaline. And we often call those these classic psychedelics. And MDMA isn't a classic psychedelic by that definition. If you define psychedelics as I like to, which is drugs that induce an altered state of consciousness that may have clinical value, then you can call them a psychedelic, sure. So, and loads of other drugs can have psychedelic properties. Tetrahydrocannabinol, THC, high dose, ibogaine, salvia. They're not classic psychedelics, but we certainly call them psychedelics. Ketamine, at dissociative doses is clearly psychedelic in the way it works. So you're correct in one way. It's not a classic psychedelic in terms of being in that top 4. But if we think of it as an agent that alters the state of consciousness, then we can certainly call it that.
Thank you. So the next question is from Julia. Apologies if I pronounce anyone's name wrong. So anecdotal evidence suggests that MDMA should be taken not more than every 3 months. So our first question is this backed up by evidence? And our second question is, if so, how does that affect the use of MDMA in trauma-related therapy, assuming the need for multiple sessions?
That's interesting. Even the term anecdotal evidence, I mean, it's more like anecdotal observation, isn't it? Because kind of by definition, it's not evidence. I guess what you're getting at is there a sweet spot for the number of times to take MDMA and it still works? I think the bottom line is less is always more. If you look at the way it's used in research protocols, I mean, we offered 2 sessions and that was it, spaced 3 weeks apart. And that's certainly not going to cause any harm. I think, it's a good question. The whole point about doing MDMA-assisted psychotherapy is that you're trying to offer a single, discrete, curative treatment using psychotherapy and the MDMA to then not have to take medicines again, not have to take daily medicines, not even have to repeat the course. A study done in the States with PTSD and MDMA, they gave a course of MDMA, patients got 2 or 3 sessions of MDMA, and then they got no further MDMA. They were followed up at 3 to 4 years later, and all of the positive effects have been sustained. So there's certainly no suggestion that people need to keep taking the drug in terms of a treatment. What we're aiming for is to do a course of the therapy, 8-10 weeks, whatever, take the drug 2 or 3 times, and then you're better. Now, it may be in the future that it might make sense to repeat that course every year or every couple of years, but you certainly don't need to keep taking it again and again and again. So I hope that answers your question.
Okay, so the next question is from Jenny. So she says, hi Ben, thanks for the talk. You mentioned attachment theory. I wonder about MDMA allowing attachment to the therapist as it reduces the fear response, and even more importantly, whether this allows an internal attachment/relationship to help develop a more positive self-narrative. What are your thoughts?
I concur with everything you've just said. It does indeed do all of those things.
Question from Megan. So I think this is quite a common question. So regarding the come-down effect that many people experience after the effects of MDMA have worn off, how would you overcome this when using the drug therapeutically?
Okay, great question. I mean, I think first thing to say is look at the way people take ecstasy, right? And I'm paraphrasing this because some people take it differently, but how do most people take ecstasy? What do? They go to the pub, they drink 3 pints, they go to a club, they drop a pill at midnight, they drink a few more pints, they do another pill at 2 o'clock, they have another couple of pints, they do another pill at 6 a.m, they go back to someone's house, they sit around listening to Pink Floyd or techno, and they smoke endless spliffs and drink endless cups of tea and do a line of cocaine and do a line of amphetamine, do another half a pill, do a line of ketamine. Maybe by Sunday night, they just about get about 2 hours sleep and a cup of soup. Then they go into work on Monday or Tuesday, they feel like crap, and then they go, oh man, it's my serotonin depletion because of that ecstasy. It's not, it's a hangover. You've just totally caned it all weekend. You've had no sleep, you've had no food, you've danced your socks off. You've taken loads of other drugs. Also, God knows what was in that pill. Was it MDMA or whatever, anything else? So what this tells us is we cannot make inferences about clinical MDMA based on recreational ecstasy users, whatever they are. Because what even is an ecstasy pill? It's what someone told you it is. So clinical MDMA, when we give MDMA, we give MDMA at 9:30 or 10 in the morning. The patient comes in, they've had a wonderful sleep. They come in, they're all prepared. They've spent weeks preparing for this moment. They take the MDMA at 10 in the morning. They're up throughout the day. They plateau through the afternoon. They come down by 5 or 6 in the evening. They feel great. They've done a hard day's work with these 2 therapists. They eat a meal. They sleep like a baby, and they feel great for a week. So we can't blame ravers and their hangovers on MDMA, because you really need to control for all of those other confounding factors. Now, some people don't take MDMA like that. Some people do it in a very sensible way. They take very pure MDMA samples during the day. They don't miss out on sleep. I think, going back to your question, by far the biggest problems that cause the apparent MDMA hangovers are lack of sleep and excessive exercise, not to mention impure sample. So, and concomitant drugs. So if you, going back to example, what can we do to make it more pleasant? One thing's about dose, right? Now, think about dose. With the sweet spot dose for MDMA is around about 120 milligrams. When you exceed 120 milligrams, what you do is you flood those 1A and 1B receptors, the euphoric ecstasy effect. And then thereafter, any higher doses, all you're doing is increasing the dopamine and adrenaline effect. That increases the, so when you get people at raves that take a pill and then 2 hours later 2 pills and then 3 pills, all you're doing is just flooding the receptors with stimulation. You're losing the euphoria ecstasy effect. People who really know how to take MDMA, they'll take a pill at midnight, then at 2 they'll take half a pill, and then at 4 they'll take a quarter of a pill, and then at 6 they'll take an eighth of a pill dose every 2 hours. That way you stay on the X. If you're just going to take more and more and more and end up with a blood saturation of over 120 milligrams, you might take something cheaper like coffee or amphetamine. You just, and that's why you see people wandering around raves at 8 in the morning, gritting their teeth, big wide eyes, wired out of their head, but not feeling particularly euphoric and ecstasy-like. So less is more when it comes to MDMA. And I'm very happy to say all that. It makes it sound like I'm condoning recreational drug use. I wouldn't flatter myself to suggest that anything I say is going to make someone take MDMA. People take MDMA in the bucket loads, regardless of anything Ben Sessa says. But what I am going to say is, if you're going to take it safely, and less is more. Half the dose, don't increase the dose, keep it low. And ideally, don't do it at night, do it during the day. Don't miss out on sleep and food. Don't dance. What a boring raver I am.
So I guess that ties in nicely to the next question, which is about the current UK governance. So essentially, what is the legislation on it? And the reason why I think it links in is there's a lot of stigma around a lot of these psychedelic drugs. So what is the current stance? And another person also asked, will it need to change in North America first before we can see a change in the UK?
Well, the current stance is unambiguous. It's illegal. It's well, illegal drug is a bit of an anathema. It's a banned substance everywhere. There's nowhere in the world that MDMA is licensed as a medicine, and in the UK and in America, it's a banned substance. There are it's a Class A substance in this country. There's very strict penalties for possession or supply of MDMA. So that's unambiguous. It's a Schedule 1 substance, which means it's not a medicine, which means it's not available as a treatment. It's only available as a experimental research compound, which is why we can only use it in research protocols, which is why we're using ketamine in our clinic, not MDMA at this stage. How will it change? When will it change? Well, how or when it changes as a recreational drug, who knows? Who knows? What's for certain is it's going to be different in different countries all over the world. No country yet has achieved MDMA as being available on a regulated market. Some countries, such as Portugal, have made MDMA not a criminal offence to possess a certain small amount. So if you look at the scale of from total prohibition to completely free availability, total prohibition is the situation where we are at the moment with cannabis, MDMA, LSD, magic mushrooms, whatever. And at the other end scale, complete availability like tea or coffee or sugar. Anyone can buy and sell it. You don't need a license. Then you've got all sorts of steps in between where you've got like decriminalization, and then eventually you've got regulated market, but still not freely available. And then you've got freely available. I think that hopefully what needs to happen is all drugs from cocaine and heroin to MDMA, LSD, amphetamine, magic mushrooms, etc., should be available in a regulated market in which we can control the management of the production, supply and distribution of all of these drugs for people to use for personal growth and development, like they do anyway. At the moment, we've handed that entire franchise to the mafia, Banning drugs is a ridiculously stupid thing to do. It does not make them go away. If you ban things, they don't disappear. All you do is you hand the franchise to the mafia, who are more than happy with the drug laws. If there's one group of people who do not want any reform of drug policy, it's the criminal network that make, produce, and distribute drugs. So what we could do, any Home Secretary with the stroke of a pen could change this and save billions and make billions. And there is the blood on the hands of successive Home Secretaries in this and every other country for this ridiculous, unpoliceable, unethical war on drugs policy that's killed too many young people for too long. It is going, we are seeing the embers of the war on drugs as the fire dies down. I have no doubt that within 10 or 20 years, it will all be over and the drug problem will have miraculously disappeared because it's only a problem because we make it a problem. Here's a catchphrase by Ben Sessa: drugs don't kill people, prohibition does. Every single drug death that I've been involved in, and it's a great many, every single drug death has been due to drug prohibition, not the pharmacology of the drug. They could all be prevented. And here's the thing, most people take most drugs most of the time benignly. That's a fact. Even heroin and crack cocaine. There's this kind of idea that if you use heroin or crack cocaine once, you die. You just simply don't. And we have so many deaths, nor do you immediately become addicted. If that was the case, there'd be queues around the block for every addiction center. Even these nasty drugs, most people take them most of the time benignly, just as they take alcohol benignly. You don't have one sip of beer and die, nor do you take one toke on a spliff and die. There are deaths associated with drugs, and where they occur, it's almost always because of the prohibition and the dangers that brings. So let's be sensible, let's move forward. We're going to do it anyway. It's just which politician is going to have the balls to do it first.
Okay, brilliant. So obviously with a lot of people interested in MDMA and other psychedelics. So a question from Joe, and I'm just going to expand the question slightly as well. But what would you suggest for current undergraduates who are interested in this field? Is there potential for internships or perhaps master/PhD projects? And are there any information sources you would particularly recommend reading?
There's a great book called Psychedelic Renaissance, actually. It's well worth a look. 2017 edition, it's got lots of nice photos. Loads of things you can do. I mean, first of all, what do you want to do? What do you want to be? Do you want to be a therapist? If you want to be a psychedelic therapist, an actual clinician, first thing you got to do is become a clinician. We're going to be doing therapy training courses out of our clinic in Bristol, Awaken. But what we can't do is turn non-clinicians into clinicians. If you want to be a psychedelic therapist, you have to consider psychedelic therapy as a specialist form of psychotherapy. So you can't do a 3-week course on brain surgery and call yourself a brain surgeon. You need to be a brain surgeon, and then you can do a specialist brain surgeon course. It's the same thing. So there's many ways of being a therapist. Probably the quickest, shortest route is to become a counselor. I think it's about 3 years. Or there's a clinical psychologist or a medical doctor like myself, or a social worker or an occupational therapist or a nurse or a clinical psychologist, psychotherapist, but you have to be a clinician first. We can't turn a non-clinician into a clinician just by teaching about psychedelics. The amount of people who email me and they go, "Oh, Ben, I really want to be a psychedelic therapist." And I write back and go, "Why?" And they go, "Because I love taking LSD." You know, that is not a good enough reason to be a psychedelic therapist. You should want to be a psychedelic therapist because you love working with patients and you've worked with patients for years. You like working with depression and trauma and child abuse, and you've spent years working in wards, clinics, police stations, people's homes, knowing your patients, knowing about dissociative disorders, knowing about trauma, consent, confidentiality, suicidality, pharmacology. When you've got all of those things under your belt, then do you train in the specialist form of psychedelic therapy. So the number one thing to do if you want to be a therapist is get a clinical degree in any one of those modalities. But now the other thing, though, it's not just psychedelic therapists we need in this field. This field is brand new. This is embryological. We need everything. We need artists, musicians, lawyers, designers, architects, chemists, botanists, media people, writers, content writers. We need all sorts of different professions to come and join into the psychedelic profession. So get involved. Don't let people put you off either.
Brilliant, thank you. So someone has asked about, is there any research on MDMA and complex PTSD?
Loads of research on MDMA and complex PTSD. So, you know, the MAPS, the Multidisciplinary Association of Psychedelic Studies, which is spearheading the development of MDMA as a medicine for treating PTSD, all their work is on PTSD. Now, complex PTSD, it's such a weird diagnosis. When I started doing psychiatry, there was just one thing. It's called PTSD. And we now have these two different types. We have what's called simple PTSD and complex PTSD. Complex PTSD is just about every single traumatic-based disorder there is. Complex PTSD is when a patient has had repeated, not necessarily life-threatening, but nevertheless no less frightening episodes of trauma, usually in childhood, and the resulting phenotype is the same as what we might used to call simple, now we now call simple PTSD, which is this presentation of avoidance of trauma stimuli, hypervigilance, flashbacks, nightmares, depression, anxiety, those kinds of symptoms. There's loads and loads of work that that demonstrates that MDMA is very good at helping those people. Like I said in the talk, MDMA puts you into this mental state which allows you to address trauma in a way that you wouldn't normally be able to do. So lots of work in this field, but we're always looking for more. So get yourself some funding and do a study.
Brilliant, thank you. Are you okay to take 2 more questions?
I'm happy to take as many more as I can manage before I'm too hungry.
Perfect.
15 minutes?
So a question actually from myself. So I know that your background is also child and adolescent psychiatry. Do you see the potential use of MDMA or other psychedelics in treating mental health issues in an adolescent population?
Absolutely, 100%, totally. Why not? One of the things you learn very quickly in pediatric prescribing is it's unethical to not give a child a treatment that is safe and efficacious. It's quite strange that sometimes people go, you can't give it to children. Well, hang on, if it works and it's safe, it's unethical not to give it to children just because they're a child. That is really unethical. You know, most of the stuff that we give for children has not been tested in children. But we do it because we know it can be demonstrated to be safe and efficacious. Would you say the same thing about, I'm not going to give this child a epilepsy drug or a renal drug or a cardiac drug, even though it's safe and efficacious, but because they're a child, I'm going to withhold it from them? Of course you wouldn't say that. It's deeply unethical. So there's no reason why we should have a different rule for psychedelics. Psychedelics are safe and can work. Children absolutely deserve that treatment as much as adults. I have seen too many teenagers lose the battle and die and kill themselves in adolescence because they've been unable to access the correct treatments. That's not good enough. If they can be shown to be safe and efficacious in children, then absolutely they should be used.
Yeah, so hopefully in the future we can see some changes in adolescent psychiatry as well then. So a question from Alex. So she said, you have talked about the mystical experience of typical psychedelics had a high correlation with positive outcomes. Have you found a similar thing with MDMA in terms of the level of empathy connection? Also, the typical psychedelics have shown to increase nature connection. Is this something that has been shown in MDMA-assisted therapy?
Superb question. You win question of the day. Yeah, that's a great question. Absolutely. I mean, one of the things about psychedelics, and MDMA is the same as this, whether it's ibogaine, ketamine, MDMA, cannabis, even for some people, LSD, psilocybin, for many people that have not experienced this, that mind expansion, consciousness expanding experience is what we call a peak experience. It's so different from everyday life, and it has profound effects on the way you go forward. Now, even if you do it recreationally without psychotherapy, it can have that effect. People talk about how they've changed since they've taken their psychedelic. And we see this with MDMA. And even though it's not, as I said, a typical mystical spiritual experience as it is with the classic psychedelics, it's nevertheless a life-changing, profound experience. And we probably know people like this they might have been one sort of person, they take their first E and they're just different. They're just like, wow, they've just got a different outlook on life. And we've seen this, and we saw it a lot with the patients. And especially then, when you then channel that through psychotherapy, and you're actually using it to address particular issues that have kept this patient in this rigid, stuck position for so many years, they do make life-changing experiences. You know, it's like, wow, I can suddenly see my brother in a new light. I'm going to now write a letter to him. It's different. I now realize that when he did that to me when I was 6 years old, things must have been really difficult at the time. And this MDMA experience has really shown me that I don't have to hold on to those old narratives. So absolutely, psychedelic experiences, when well honed and controlled and managed and within a supportive, facilitative psychotherapeutic environment, do have this tremendous capacity to affect lasting positive change. And you see this in lifestyle. People give up eating meat, they get more exercise, they get more interested in meditation and nature, because MDMA just has this capacity to do that. Classic psychedelics do too. They do really cut away the crap of life. And, you know, take LSD and go to a supermarket, right? You will be in fits of laughter as you walk around the shelves, and the sudden come to the realization that 98% of the rubbish on the shelves is utterly useless. We don't need 50 different types of pasta, 28 different types of hummus. It's completely superfluous. It does strip away these aspects. What's really important in life? People, connectivity, love, children, you know, psytrance. You know, what's important in life? You learn these things through psychedelics. It does take away the superfluous aspects and helps you concentrate on the most important thing. I don't mean that about psytrance. I hate psytrance.
Thank you. That's a brilliant answer. And I hope, Alex, you enjoyed that answer as well. So a question from Clarissa. Which models of psychological therapy were used in the MDMA research and in clinics more generally? And just to pair that with another question I saw, which was, is the psychotherapy used with MDMA similar to the one that's used by when people take doses of LSD or psilocybin?
Okay, I like that question. What model? Now, I've got two answers to this. What model did we use in our MDMA study for alcoholism? What psychological model? The really easy, really lazy answer is we used MDMA-assisted psychotherapy for treating alcohol use disorder therapy model. Now that's a really crap answer, but actually it's true. It's never been done before. No one's ever done this. So it's fair to say we were making this up as we went along. We had no blueprint to use. There is no manual of how to use MDMA to treat alcohol use disorder. So we had to borrow from all sorts of other things. So that is a reasonable answer. And as time goes on, we will write the manual as to how to use MDMA and then there will be nailed down, this is the model for using MDMA to treat alcoholism. So that's my lazy answer. Slightly more nuanced answer is, well, we used aspects of other different sorts of psychological models. For the MDMA session itself, it was quite closely aligned with the MAPS manual for treating PTSD, where there's a lot of transpersonal psychotherapy. But because this was an addiction study, we also used a lot in the way of the typical models we might use for addiction. So motivational interviewing, motivational enhancement therapy. We talked a lot about risk factors for drinking and relapse and what are the triggers for that. And we used a lot of behavioral aspects as well, you know, like don't go to the pub next week. If you go to that wedding next week, can you drink lemonade rather than beer, you know? So there was a mismatch of different psychological approaches, but all I can say is we're in the process of writing the formal model in which we'll set out the psychological model that's used for this kind of therapy.
Okay.
What's the other question? Maybe?
Sorry?
What's the other question? Was it about dose?
No, the similarities between MDMA-assisted psychotherapy and psilocybin-assisted psychotherapy.
Okay, that's a cool question. In my opinion, the similarities between MDMA, psilocybin, LSD, and ketamine are greater than their differences. Okay. Now, I'm not so naive. I know enough about these compounds. I'm not so naive to suggest they're all the same effect. They're quite radically different subjective psychological effects. However, when it comes to as I said earlier, inducing an altered state of consciousness in which you can do work clinically, there's massive similarities between all those three. And of course, the length of time is different. The extent of ego dissolution, the extent of perceptual effects is different across all of those, the affective effects. But really, the thing that links them all is it's the skill of the therapists to affect a positive therapeutic working relationship, whether it's with ketamine, MDMA, psilocybin, LSD, doesn't really matter. It's how well are you doing in terms of creating a positive therapeutic effect with your therapists and the patient. And then all of those medicines can be useful. Now, one thing that's quite interesting, we've seen in recent years these compounds and different sorts of psychiatric indications falling into pigeonholes. So we've seen MDMA for PTSD, we've seen psilocybin for addictions and depression, we've seen ketamine for depression. But one of the reasons we did the alcohol study is because I'm really keen on broadening this, you know, I'm really keen on, I think this is in its infancy. 10 years from now, I'm pretty certain all of these different psychedelics will be used for all different psychiatric indications. We won't be so pigeonholed. The one way I look at it is any psychiatric disorder that responds to psychotherapy will respond better to psychedelic assisted psychotherapy. And when I say any psychiatric disorder that responds to psychotherapy, that's everything from schizophrenia to eating disorders, to personality disorders, to affective disorders, anxiety disorders, psychosis. All of them have some kind of psychotherapeutic program. I would argue that any psychedelic assisted psychedelic program would be even better. So we're going to see a massive broadening of how these medicines can be used in psychiatry.
Brilliant. It's amazing that it's all still in its infancy, but it's already showing so much promise.
These early days.
Perfect. So I've got a question from Irini, and apologies if I pronounced that wrong. So thank you, Ben. A lot of people have been saying thank you as well. It's not just questions that have come in. And a lot of people loving the passion that you have delivering this topic. So her question was, what is your understanding of the difference in consciousness shifts between MDMA and classical psychedelics? And how do you think it relates to a transformative change achieved in relation to the self?
Oh, God.
Very deep question.
What is my understanding of the consciousness? I mean, so the classic psychedelics like psilocybin, LSD, they are much, much stronger at dissolving ego, dissolving sense of self. And that can be very valuable. And you don't get that with MDMA. So I can recall a high dose psilocybin experience when I was injected with intravenous psilocybin. And I'll talk you through it. I was lying in an MRI scanner. This is a study we did with Robin about 10 years ago in Cardiff. There I was lying in the scanner. Pretty much the worst place ever to take a high dose psychedelic, right, is inside an MRI scanner, let's face it. So I was lying there inside a metal tube, plastic tubes up my nostril, a needle in each arm, metal straps holding me onto a metal tray, locked inside this tube for an hour, being injected with high dose psilocybin. Now, as I lay there and the drug went in, and you go, it's like being fired out of a cannon, right? You go from baseline to tripping more than you can ever possibly imagine in about 40 seconds. And I would lay there, and the first 10 seconds, it's like, right, my name is Ben. I'm a father. I'm a husband. I'm a doctor. I'm taking part in an experiment in Cardiff. 10 seconds later, right, my name is Ben. I'm a father. I'm a doctor. I'm a person, but I don't know where I am. 10 seconds later, right, I'm a human being somewhere doing something, but I've got this body and something's going on. 10 seconds later, what's a human being? 10 seconds later, there is no time, there is no space, there is no me, nothing has ever happened before, nothing ever will happen, there is no universe, there is no me, I've completely lost everything there possibly was. 10 seconds later, I'm not even asking any questions, I just have become white light. I'm not even looking at white light. I have become white light. And that's all there is ever been. And I can't even ask questions like being, because that doesn't make sense. So basically, total legal dissolution. The layers came off me like an onion. Now, as I came out of the experience and they wheeled me out jelly-like, and I come back to life and slowly begin to talk again, what really occurred to me is, wow, what an incredible clinical tool, okay? What a superb clinical tool, because we carry around with us narratives, labels we hang around ourselves. Some of them are really good, normal things, like there is a thing called gravity. There's an up and a down and a left and a right. And there's things like time and space and people. There's traffic lights, there's buses, there's relationships, there's mothers and fathers. There's my job, my sex, my gender, my interests. These are all very benign. But what if my labels are, I'm useless, I'm a failure, I deserve to be raped, it's my fault, I'm bad, I'm unlovable, the things my patients tell me, these narratives. Now, one of the superb things about how psychedelics works is when you've had such an intense experience where the very fabrics of your narratives, of your beliefs of self and world have been so stripped away, that there is not even the fundamentals like gravity and time and space, then when these layers come back and you start to build up who you are, you're in a really strong position to say, do you know what? I'm going to keep gravity. I really like that. That was useful. I'm going to keep time and space. I'm going to keep that I'm a man and I have a human body. Those are good. But that stuff about me being a useless failure, I just don't need that, because I can choose which narratives I'm going to bring back. So does that make sense? This concept of ego dissolution, you've glimpsed such a profound upsetting of what we call normal, that when you come back, when that is done in combination with psychotherapy, you're in such a strong position to decide which bits not to take back. And that I was describing there a high dose classic psychedelic ego dissolution. Now we don't get that so much with MDMA, but what we do get with MDMA is the positively felt mood and the heart opening warmth of MDMA does allow you to say, do you know, that little 6-year-old girl that was raped by her grandfather that I don't have to carry that with me, because I've seen so much love and I've felt that in this drug experience. And I know I'm capable of that. I know it's in me. It wasn't that little capsule that Ben gave me. That capsule didn't contain love. It contained a key, a catalyst that allowed me to see my love. And my love was always there. And I'm a good person and I'm full of love. And I've now, for a few brief 6 hours, glimpsed what it's like to be the true love that's inside me. Sorry, forgive me if I sound like a hippie. It's not my normal style of speaking, but I'm on one now. And that is immensely therapeutic, you know, to have had that glimpse. Now, as I said, it's much, much more powerful when that's done in a psychotherapeutic relationship. Sure, you can just take it with your mates and have a laugh or go to a rave or a festival, still be good fun. But imagine doing it when you spent weeks and weeks and weeks working on those particular issues with a therapist. Then you take the medicine, and you have more weeks of unpacking. Then you take the medicine again, you have more weeks of unpacking. It's a very, very powerful psychotherapeutic experience. Hope that makes sense.
Yeah, it really does. And I think just listening to you, I can feel all the warmth and love as well. And I hope everyone else can. Okay, so I think we've been... Sorry?
I'll have what you've taken.
A stressful evening, that's for sure. So I think we'll have just one more question then, which is from... So apologies to anyone who I haven't been able to answer their questions. Ben, are you okay if people do contact you via Twitter or email if they do have any other questions?
Yeah. Contact me at ben@awakenlifesciences.com.
So the last question then is from Catherine Taylor. She asked, should clinicians be fearless in talking about this in everyday practice?
No, we should be shouting this from the rooftops, obviously.
Brilliant. Okay.
Yeah. I mean, I'm in a really, really strong position, right? Because I can say on the record that I have taken MDMA, LSD, psilocybin, DMT, and ketamine. I can say that as a working doctor, a doctor that works with children nonetheless. I can say that on the record because I've had all of those drugs in a legal research capacity, legally, okay? Now, I may or may not have taken illegal drugs. I've never, ever once in my 15 years of practice, ever said in one single presentation, tweet, or discussion that I've ever taken an illegal drug. You can judge for yourselves whether you think I might have. But I'm in a strong position to be able to say that I've taken all those legally. But we need to do something to push this, you know? An awful lot of people do use drugs. And as I said, they almost all the time use them very safely and very positively and effectively for personal growth and development, communal growth and development. These drugs bring people together. They create communities, they increase cohesion, and they increase this personal growth. I would never suggest that anybody should out themselves, but what we need to do in order to push these changes is we need to find a way of normalizing drug use. You know, the way the media represent drug use is in either two ways. It's either totally sensationalist, as in take LSD and then you can go and live in a yurt in Totnes and commune with the Godhead, which is nuts. Yeah. Or if you smoke a spliff, you're going to die of an overdose tomorrow. You know, there's what we don't have in the middle is people just take drugs. They just take them. They don't die, they don't become enlightened, they just take them and they're fine. So I'm going to challenge you guys in the audience here, because you're much cleverer than I am, to come up with some kind of creative way to get this message out there. Because I can tell you, evidence-based practice does not seem to work. Myself and David Nutt have been doing this for 15 years. I've been plonking endless piles of data onto the secretaries of successive Home Secretaries about the safety and efficacy of evidence-based safety and efficacy of drugs, and it's got absolutely nowhere. What we need is something more creative. We need the arts. We need documentaries. We need storylines on EastEnders. Yeah, here's a great storyline. I've got one for EastEnders. Bloke goes up to the other guy in the market, says, "All right, mate, what you doing?" He goes, "Oh yeah, took ayahuasca last night." And the other guy goes, "Oh yeah. Anyway, pound of satsumas, please." That's the end of the story. End of the story. That's how we represent it. And that's kind of what's happened, say, look at another group, like say, changes with homosexuality, yeah? Now, we needed the broken windows and the street protests of the 50s and 60s. We needed that. We needed to get this message out there, because the vileness and the unethical aspects of homophobia, and the same with women's rights, and the same with racism. We need the placard waving, the shouting, the broken windows, because the disgusting vileness of inequality has to be broken. But actually, it's what's really, really happened that's moved forward things like homosexuality and homophobia has not been the loud shouting, it's been the normalization. It's been like, oh, you know, Barry, that guy, that mechanic down the road, oh, he's gay. Oh, is he? End of story. That's where we need to go with psychedelics. And this is why I get a little bit pissed off with the whole hippie thing. You know, I'm not really interested in all the condor feather waving TP crystal healing rubbish. It doesn't interest me. It puts people off. Yeah, we just need normal, everyday psychedelic drug use. It's normal. Everyone does it. Get over it. Move on. Stop putting people in jail for it. So, you know, think about it, you people in the audience, because I've been doing it for 15 years with evidence-based data, and it's got me nowhere in terms of drug policy reform. We need something more creative. Please.
Well, thank you so much for answering all those questions. You've answered them all very thoroughly. I'm sure everyone's enjoyed it. Most people have stayed with us, which is really good to see. Again, I apologise to anybody who hasn't had their questions answered. As I said, feel free to email Dr. Sessa or message him on Twitter. Before we go, I was just wondering, Dr. Sessa, if it's okay if we could take a picture. So we can't actually take a picture, obviously, but if everybody could turn on their videos and then we can take a screenshot.
Okay, no, that's cool. I'd like that. I've got my appraisal on Friday. No, tomorrow. I've got my annual appraisal, so I can show that to my appraiser, and then they can realise I'm a good person and I deserve to be registered under the GMC.
Brilliant. So bear with me. So I'm going to do a little countdown, and then if Sean and Daniel could click print screen. So 3, 2, 1, cheese. Brilliant. Was that okay, guys?
Thank you very much. Lovely to see everyone. Keep going. Don't give up. Don't let anyone put you off. You're all superstars.
Brilliant. Thank you. And I'll just repeat what you said. We're all superstars. I know it's been a difficult evening, but we've got through this. And thank you so much, Dr. Sessa, for bearing with us and working through all of the interruptions. I hope everyone's enjoyed the talk. Make sure to follow us on Twitter and other social media platforms, and enjoy the rest of your evening. Thank you.
Come and visit me in Bristol.
Brilliant. Thank you, everyone.
Bye.
Thank you guys for coming.